Hello, I'm Dr. Elena Ivanina, and welcome back to another episode of Gut Love Grand Routes. And today we are elated to have Dr. Mark Pimentel join us. And I see him here. We're going to add him. And
I think I'm good.
here we go. Perfect. Hi, Dr. Pimentel. Welcome.
Hi, how are you?
I am great. I'm so excited and looking forward to chatting with you today. Thank you so much for taking the time out of your super busy schedule.
It's my pleasure. This will be fun.
Awesome. So, as most people probably know, Dr. Pimentel is the executive director of the Medically Associated Science and Technology Program at Cedars-Sinai in LA, and the author of countless SIBO papers that have helped shaped my career as a gastroenterologist and have helped so many people out there, so many patients. And I wanted to start, I got a lot of questions for you, obviously, and I wanted to organize them nicely, but really start around root cause evaluation. One of my favorite papers that you wrote was back in 2016 with Dr. Ali Rezai and Dr. Satish Rao about understanding that SIBO has a root cause, has induction therapy, and has maintenance. And it is so important to address all those issues to have successful treatment. And so I wanted to talk to you about some of the perhaps controversial root causes, because as people are searching for why they got SIBO, some things come up. And one of the first things is you've done a lot of research on post-infectious causes such as Campylobacter. What about post-antibiotics, Dr. Pimentel? We talk about people having antibiotics for other reasons, non-GI reasons. Does that cause SIBO?
Well, so that's a complicated answer because let me say it another way. There are a few studies, a very small number of studies that say IBS, which IBS and SIBO, we sort of see are
Right.
interdigitated, or at least there's 60% overlap, that you can get IBS after
Yeah.
antibiotics. But the problem was the first and the largest study that looked at that actually looked at people who just finished antibiotics, gave them a questionnaire, and then repeated the questionnaire 2 months later.
Mm-hmm.
And in the antibiotic group, there was more people who went from not having IBS to having IBS. But in the end, both groups had the same amount of IBS. But they did their first questionnaire after the antibiotics, and we know antibiotics makes IBS better. So they should have done it before the antibiotics, after the antibiotics, because we know antibiotics makes IBS better. So they were relapsing, and they were saying, oh, they're developing new IBS. So I think the jury's out. I don't think antibiotics cause SIBO. But there's another angle, which is the SIFO, small intestinal fungal overgrowth. And
Yeah.
while it's still an emerging area, it's not as well developed. It's possible antibiotics could bring that on, depending upon the type.
Indeed. And I definitely have SIFO on the list of some things to talk about today. And we can jump right into SIFO for a minute because a lot of people talk about candida in functional medicine and naturopaths. They've been talking about candida for a long time. And finally, through things like aspiration, duodenal aspirations, we can see that actually candida can grow as something that causes SIBO type symptoms. And can you just describe a little bit? I know you did a study. There's now some information about the prevalence of IBS symptoms that may be due to SIFO. So what have you found?
Yeah, so at last year's DDW, we have a study called the Reimagine study where we
Mm-hmm.
take aspirates from consecutive patients undergoing upper endoscopy, and now it's the largest collection of aspirates that I know of in the world in a single center, and so it's about 900 patients. But when we see SIBO, it is quite common. About 25% of patients with GI illness have SIBO, but SIFO is quite uncommon,
Mm-hmm.
but not zero. So there are patients with SIFO, and those that have SIFO, the symptoms are proportional to the amount of, in this case, it was Candida. We measured all the fungus, but Candida was the one that was producing the majority of the symptoms.
Mm-hmm.
So it happens, but it happens in a relatively small minority compared to SIBO.
Got it. And if you were to find, for example, that someone had both, would it be that you always treat SIBO because as the microbiome is just so much more populous in the gut that it would have more of an impact to treat SIBO first? Is there a correct way to do it, or how would you tackle it?
Unfortunately, there's no correct way to do it because we don't have a good measure for SIFO.
Mm,
Remember, we're talking about small intestinal fungal overgrowth, not stool
right.
fungus. So stool tests don't represent the small bowel at all. So the only way to get a fungal sample is juice because we don't have a breath test for fungal overgrowth. So, but if 95, 98% of patients with bloating and symptoms, and if you're going to say whether it's SIBO or SIFO, it's 98% is going to be SIBO,
Hmm.
2 to 3% is going to be SIFO. So more than likely, you're going to respond to antibiotics, regular antibiotics, rather than doing antifungals. But
Right.
I guess for the patients who worsen or the patients who don't respond to the antibiotics, it's a
Got it.
consideration.
And I've been performing the aspirate here in New York City, and I'm going to have to say I'm very much looking forward to the device that you've been using at Cedars-Sinai. I don't know if everyone knows, but there can be a lot of contamination with oral microbes when you're doing this type of procedure, obviously, because you pass the scope through the mouth. And I don't know if this is going to be commercially available soon. Dr. Pimentel, is there any news about the device to help with aspiration?
Yeah, so full disclosure, we've developed this device. It's with a company called Hobbs Medical, but they are pursuing the 510(k) approval, and then once it's approved, currently we use it in the Reimagine study as part of
Hmm.
research. But once it's approved, it's a double lumen catheter with a sterile cap, so it's the internal catheter is sterile, which it's not perfect, meaning it's a dirty environment, but
Hmm.
it dramatically reduces contamination and all that oral flora and other contaminants as you go through the esophagus.
Terrific. Yeah, Dr. Rao taught me how to do the aspirate when I was in fellowship, which I've been doing with the way that he's described. I'm going to have to say, I think the contamination rate has been low where I see the oral microbes, all the streptococcus, and a lot of times I have seen candida, and it's great to have the actual sensitivities to the antifungals. But I look forward to having a better way to do it for sure. And speaking of interesting kind of things in the pipeline, as some of my community had also asked about some things you're doing at Cedars-Sinai, which may be special, maybe how they can, get into different trials you might be involved in. And one thing that actually one of my patients I'd recommended they do with you is the allimetry test. And I'd love to hear about that and some other things that you're doing at Cedars.
Yeah, we were one of the first programs in the United States to adopt allimetry, but allimetry doesn't really help you with small intestinal bacterial overgrowth
Hmm.
yet. It measures the electrical activity, sort of like an EKG of your heart, but of the stomach and maybe the small intestine, because we'd love to be able to measure the cleaning waves with allimetry, and we haven't got there yet.
Hmm.
The allimetry currently in its current form measures stomach electrical activity accurately,
Hmm.
but we're trying to work out algorithms for the small bowel because the cleaning waves are the things that are deficient
Hmm.
in IBS that lead to small intestinal bacterial overgrowth. And so if we can identify those with low cleaning waves, then we can also treat that with a motility drug
Hmm.
and see if the cleaning waves are improved, hence titrating our effects as well. And this is all to help patients get a better treatment and or predict who's going to respond better to certain things.
Yeah, it's definitely fascinating as I reviewed some of the um, findings, and you can also see if there are clues that it's more of a gut brain axis issue as well that comes up on this test, correct?
So as the vagus nerve controls the pacemaker of the stomach, yes,
Mm-hmm.
and there's some bidirectional communication. A lot of the bacteria of the gut do produce chemicals that can affect the nervous system. For example, serotonin can be produced by bacteria, and you know what that
Mm-hmm.
can do in terms of mood and affect, and not to mention that when you have overgrowth, you do have not like Crohn's disease, but you do have this cytokine inflammation that goes on in the gut. And that also heightens nerve sensation and causes visceral pain. And so we've demonstrated that in some studies we've published just
Indeed.
recently.
Yeah, I know that you've talked before about Klebsiella, right, causing, especially through histamine, there's a lot of pain, right, that can
Yeah.
specifically Klebsiella, which is overgrown in C hydrogen SIBO. So I definitely see that a lot. Going back to the root cause diagnosis conversation we started, one of the other things that comes up that wasn't exactly outlined in, for example, the 2020 SIBO guidelines and ECG was something like mold. And this comes up so much. And I laugh because, of course, it's very new, but everybody's talking about it. And I get this question all the time. And so what is your experience been? What are your thoughts on mold and
Well,
SIBO?
I've always been of the mind since we've been, in the early days of SIBO, we were criticized because it was such a radical and maybe revolutionary idea in the
Yep.
context of IBS being an anxiety disorder rather than a real
Right.
disorder. There's nothing to dismiss about the idea, but there's a tremendous lack of science to be able to show the cause and effect. So, I mean, you can't randomize humans to 100 people. 50 people go into the moldy room every day for the next month, and 50 people go into the non-moldy room to see what they get. It just can't be done.
Right.
But there are mold toxins, and we all know that it's hard to sell a house if you have black mold in the walls. It's because it's toxic. We all know that. But we just don't know the breadth and the depth of that effect in terms of whether it dovetails with SIBO or whether it dovetails with other conditions. And so I think that's the problem we have currently.
Indeed. I think, we learned in med school, we know about aflatoxins, we know about liver toxicity, liver cancer. Like, we know that they are toxic to the body.
Right.
But as far as GI papers, I mean, I keep looking when people ask me, but it really, there's so little information about it. Structural issues causing SIBO. Also, something that kind of comes up is a tortuous colon. Us females are longer colons, right? We got a couple extra inches on our colon. It's usually a little more windy. But does that put you at higher risk for SIBO?
So, sort of. A longer colon doesn't mean abnormal health. I've had patients who are perfectly normal. We're doing screening colonoscopy and we're like, gosh, we're putting the whole scope in because it's just so long.
Yeah.
But you talk to them after and they say, no, I'm going every day.
Right.
So it's not the perfect predictor.
Right.
But as you can imagine, if you can't get stool out and it builds up and it stretches everything, things do get stretched. But when we talk about constipation, which I think is where you're going with this, if we see methane on the breath test, more often than not, that's the cause of the constipation, and whether that constipation leads to stretchiness of the colon, it can happen. But then there's the other, which is colonic inertia. And those colons are very long because the colon just doesn't move. And they don't have SIBO in the usual way. They do have hydrogen SIBO because everything's backed up all the way up to the wazoo. And that's a problem. So you have to take the colon out sometimes for those
Right.
patients. Otherwise, they're not going to get better. So it's not just sort of a long sigmoid. It's more complicated than that. And to be frank, people do take the sigmoid out of these patients with constipation.
Sure.
Doesn't do very much. So
Interesting.
that
Yeah.
windiness in that sigmoid colon, if you're going to take a colon out for colonic inertia, it's all or none. It's that, unfortunately, it's not. I'm not. We have to do better with that disease, but that's the way it is these days.
Interesting. Perhaps if there's diverticulosis in that sigmoid segment, which is so prevalent as we all get older, and diverticulosis is associated more with methane,
Yes.
possibly that could be something that would make a difference,
Correct.
possibly.
Correct. And we're trying to knock methane down. We have a couple of exciting things coming up that can't talk about yet, but
Okay.
we've got them in the lab, and it's looking very exciting.
DDW?
No, past DDW.
Oh, okay.
Yeah, we have some good things at DDW though, but really good things. But this one has to wait because there's more work that needs to be done.
Okay. All right. Well, we always stay tuned to everything that comes out of your lab because it's always so interesting. Another root cause question: adhesions. How do we find them? Is it small bowel series, 20, 30 images, repositioning? Should we do that? Should we be doing that?
You've obviously been listening because 20, 30 images is right. I mean, I get referrals from outside centers. Upper GI has been done, and then I get the pictures. Just one picture of all the barium in the whole gut. They charge the same amount as we do. We do 23 pictures, isolating every single loop of bowel. I don't do it;
Wow.
the radiologist does it. But our professional radiologists look at every single loop. And inevitably, not inevitably, but often we find an adhesion that was missed by this single picture barium.
Of course.
Nobody likes barium anymore. Everybody wants to do CT and MRI, and barium's not sexy, but it is very, very effective at finding these adhesions if you have the right technical person. And it's sad because patients can go years and years and years and years,
Mm-hmm.
and
Oh, I don't know if I can hear you. Can you hear me? That's okay.
it off. So
That's okay. So perhaps, and I'm trying to actually find a good radiologist here in New York City, which you think I'm in New York City, right? I would find someone who could do this and do 20 to 30 images and reposition, but it's actually very
it is
tough. It's actually, even at
tough.
the big academic centers, it's like a dying art, perhaps, this, or very, very specific art. And I don't know, I guess, would you, say, like, as a tip, for someone looking for adhesions, is there, you say 20 to 30 images, and then repositioning, is that random, or is there really like a specific protocol that your radiologist does?
I mean, I don't follow their exact protocol in the sense of how they do it and in what
Got
order, but
it.
there are two people at our institution who are more senior because
Mm-hmm.
you don't grow up saying I want to be a barium radiologist, and but they've done it for decades and
Yeah,
they're just so good at finding the smallest thing, but it makes all the difference if you find
right.
it. And the other thing we find is some people had appendicitis they never knew. It just healed. It formed a scar in the ileum, and the ileum is tethered or is narrowed, and that's the reason they have overgrowth. It's a physical obstruction.
So that is, that's so fascinating because, again, in people who are really struggling to find the cause of their SIBO, like, it can be very cryptic. It can be
Right.
so cryptic. Like you said, someone had, there's appendicitis that could have resolved. There's chronic appendicitis, then, kind of smoldering. Like, there's so many things that are not checked for on a regular basis, right? That could be, again, forming adhesions, which, again, are so hard to find. Um, one more question about the root cause section is low stomach acid, right? We know from, again, in your in the SIBO guidelines from 2020, stomach acid one is something that can protect you from, SIBO. Now that the smart pill is basically gone, I'm not sure how we can even really check for stomach acid, in kind of the academic sense. But what are your thoughts on, checking? Do we check for like vitamin B12, iron, see if there's like a, obviously check for autoimmune gastritis? How do we check, and what are your thoughts on the association with SIBO?
So there's low stomach
Mm-hmm.
acid, and then there's no stomach acid. And
Mm-hmm.
then there's drug induced sort of in between. So there's sort of three states. But how much acid do you need? So, for example, if you had a petri dish of E. coli and you wanted to put a pH 1 chemical on it for 2 minutes, would that be enough to kill the bacteria? I
Mm-hmm.
think so. 2 minutes.
Mm-hmm.
So if you put people on a PPI, there's always breakthrough
Yeah.
in the 24 hours. Maybe that's enough because when we looked at the reimagined data, the people on PPIs, they didn't have more SIBO.
I saw.
They
That's, yeah,
didn't have more SIBO.
crazy.
So
Mm-hmm.
so I guess there's enough breakthrough during the day. But then the other thing you're talking about is atrophic gastritis, where it's
Right.
literally no acid,
Right.
and that's chronic. So that is a risk factor for small intestinal bacterial overgrowth. But then there's another thing where people are taking acid, like betaine
Yeah.
HCl.
Yes.
So it turns out the methanogens can use hydrogen gas, they can use ammonia for hydrogen source, and they can use
Mm-hmm.
acid for hydrogen source.
Mm-hmm.
So what we see in patients taking PPIs is they have more often they have methane on their breath
Mm-hmm.
test. So the question is that increased acid or is acid contributing to methane? Sorry, I said it wrong. When they're on PPI, they have less methane
Yeah.
because by decreasing the acid, you decrease the hydrogen source to the methanogens in the gut, and they're
Mm-hmm.
producing less methane. So acid can be good and bad depending on who you are and what's going on.
Interesting. Have you ever recommended a PPI for methane overgrowths for symptoms even?
Sort of. I mean, we've been dabbling with lovastatin for
Right.
over the years, but using the
Right.
PPI more to facilitate lovastatin not being converted to a hydroxy acid. And now I'm getting into the weeds. but to try and keep the lovastatin in the
Yep.
gut. But no, I've never given a PPI simply for methane.
Interesting. Something that just came up, there are so many questions. I mean, well, I could talk to you forever, but something that came up that a lot of people are worried about that I did want to address is, you do the induction, let's say the root cause, you do the induction therapy, and then as part of the maintenance therapy, you're doing low FODMAP or low fermentation diet. And patients can be very anxious about like, oh no, what if I eat the wrong thing? Will that bring back my SIBO? True or false?
False. So the reason we developed low fermentation diet, and we developed this in the early 2000s, was two reasons. And I told our dietitians we were working with, I said, these are the parameters. I want my patients to live normally. I want this diet to be such that if they showed up at a restaurant with their friends, there would be at least one thing on that menu that they could pick and eat without causing a fuss. Because the worst thing at a table is you got 10 people at a table or 8 people at a table and you take 10 minutes with the waiter because you are asking 50
Yeah.
questions. And so I want people to be, I want it to be lifestyle correct.
Yeah.
And then what the other thing I do with my patients is if they're on the low fermentation diet and they come to me and they say, this is challenging. I'd like to eat some things. And I said, well, tell me one thing you love and you're missing. And they say ice cream. I said, well, then go for it. Once every 2 weeks, have a little bit of ice cream. But you can't make it regular. And then somebody said, well, what if I have broccoli or asparagus or Brussels sprouts? I said, well, if I say yes and you have Brussels sprouts on Monday, broccoli on Tuesday, asparagus on Wednesday, that's not working because you're basically having the bad thing every day.
Every day.
So whatever the bad thing is, if you do it once every week or two, just a small amount, it's not going to change anything.
Right. So yeah, so a lot of people are worried, food bringing back
Yeah.
SIBO, but it's more like an infection will bring back SIBO. A poor motility, right, will bring back SIBO. COVID could bring back
Yeah,
SIBO,
it's
right? Things like
not the diet is, there are red lights, there are yellow lights, and there are green lights
yeah,
in the diet. And if you follow the red lights, you're doing most of the work. And it's not too hard.
yeah.
It's really not that hard.
You have a couple more
Sure,
minutes left? Okay.
sure.
Pam, one of the awesome SIBO advocates here on Instagram, she had a question about how do you test for stomach acid, Dr. Pimentel? What do you do?
Well, there's a number of ways you can do it, but the best way is if you have a pH monitor, and we do this sometimes to look for atrophic gastritis before the endoscopy, is we just push the pH probe all the way into the stomach, past the LES, because normally you place it 5 centimeters above the lower esophageal sphincter. But if you just keep going, you'll be in the stomach and you leave it there for 24 hours and you can see the entire 24-hour profile of acid.
So can we use a Bravo pH capsule for
I,
this, or is this more you're talking about like the impedance catheter?
I've never attached a Bravo to the stomach. The stomach lining is a little more, maybe less adherent because it's not a squamous mucosa. Squamous is tougher,
Yeah.
so the Bravo will hold on better. I've never tried to hold the Bravo on the stomach, but it's possible, I guess. Never done it.
I guess, yeah, that's could be something to think
It's
about
your
for
new
me. Maybe.
technique.
Indeed, right? Kind of a big picture question, right? So it's so exciting now to have Trio Smart. I'm actually really excited. I'm doing a collaboration with them on how to prepare for the test because people have a lot of questions, right? Can you take PPIs? Can you not take PPIs, right? So many questions. And so we have this great test that tests for all three types of SIBO now. And the question is, I guess, what are your thoughts? Are all three going to be different with different root causes, different treatments, different diets? Is that where we're going?
Okay. So, so the way IBS works and way SIBO works in that aspect, not the other root causes like adhesions. You get food poisoning, you then get the neuropathy of the gut, and then the neuropathy of the gut leads to SIBO. In that profile, you end up with two different possible directions that you go, microtypes. One is hydrogen sulfide, which is a little less common, and the more common is hydrogen, which is the E. coli and Klebsiella we talked about earlier. So that's the story of how you get to those two. And that story works for humans. It works exactly the same in the lab animals. We just published that paper a month ago. that's the story perfectly.
Mm-hmm.
On the methane side, we don't know why. We think you've acquired methane or methanogens from your family because you grew up with your family, and then you pass it on that way, but we don't know why they go so high in some individuals. But
Mm-hmm.
once you have those three profiles, you've got three different treatments. But the question you're asking is, are we going to have three different diets? And the answer is, I think so. We haven't worked out the nuts and bolts of it, but you can imagine a low sulfate diet in a hydrogen sulfide producer,
Mm-hmm.
maybe for low fermentation or low FODMAP for
Mm-hmm.
hydrogen, and then maybe a low acid or something like that as we understand the metabolic functions of methanobrevibacter.
Mm-hmm.
It's possible. It's possible that all those things could happen.
Fascinating. I'm looking forward to it. A couple people asked about methane. I'm going to let you go in just a couple minutes because I'm so mindful of your time. But the diagnosis of methane overgrowth. So one question comes down to how the SIBO results look, right? The test results. When a patient does the diet, they perfectly follow the diet, all the instructions, they fast, they do the baseline, they blow, and starting from the baseline, they've got 50 of methane going forward. Is that real, or is that their motility is so poor that it's uninterpretable?
Okay,
What would you
so
say?
when you do a breath test, and we've known this for a long, long
Mm-hmm.
time, when you do a breath test, the lactulose fuels the
Yeah.
hydrogen. The lactulose may fuel a little bit the hydrogen sulfide, but the methane is fueled all the time because a lot of so in terms of methane, it's not methanogen, small intestinal methanogen overgrowth, it's methanogen overgrowth in the whole gut. And so there's food left over from yesterday, the day before in your colon, and
Mm-hmm.
you're either a methane producer or
Mm-hmm.
you're not. It's
Mm-hmm.
a all or none. In fact, you don't even need lactulose to know if you're a
Mm-hmm.
methane person. You just need a single sample, and the reason you do the whole thing is so you know all three
Right.
gases. But but methane is either there or not there, and 50 is typical. It's just that's not about you didn't do the prep correctly. That is exactly how the test functions. So you don't
Okay.
look for a rise. It's just if it's ever greater than 10, that's abnormal.
Greater than 10. Yeah. Because some people say three. Some people say
Some
three.
people,
Too low?
some people is me. I mean, I was the one. No, this is a true story. I mean, all the work we did in the early days was 3 or 5. We were sort of vacillating a little bit, but
Mm-hmm.
then we went to the North American consensus. Remember, North American consensus is not the Pimentel consensus. It's a consensus of experts, and
Mm-hmm.
the experts said and voted. I voted for less. They voted for 10 or
Mm-hmm.
greater. So we go with the consensus. But to be frank, we looked at that after the consensus was done, and we said anybody who has a 5 on the first measurement, 98% of those people ended up having more than 10 on one or more readings after that
Wow.
first time point.
Mm-hmm.
So we don't think it matters too much because the majority of patients who have 5 at baseline are going to end up being over 10 eventually on that test
Got
anyway.
it. Fascinating. Well, I am very much looking forward to seeing you at DDW and reporting back to the community about everything that you have to present. And I always look forward to hearing you on podcasts and just all the research you do. I am so grateful. I know my community, everyone is so grateful for everything you do and how many people you've helped along the way. So thank you. Thanks for being here today.
Thank you. I really
All
appreciate it.
right. Have a great day.
Bye.
Take care.